This one I think is going to be either the most dramatic difference for surgeons, or they're totally going to blow it off. Because like I've looked at my colleagues here at Flagstaff that do ALIFs. They have no interest in doing direct decompressions from the front. They just don't. And I get why. There can be bleeding. You increase the risk of hematoma the more bone you take away. When you're taking posterior longitudinal ligament, there's a lot of big epidural veins that are different than in the cervical spine. But effectively, you do it the same exact way you do a cervical. You take the disc out from the front to the back. Once you get back there, you actually can sneak around the posterior longitudinal ligament and stick the probe right lateral to the posterior longitudinal ligament and get the nerve root right there. I have intraoperative pictures of what that looks like fully exposed. And so I can share that with you so we can talk about where to test the nerve and what structures are what. But a lot of times you have to get the probe under the back of the vertebra as the vertebral body starts to, because it's a circle, as the vertebral body starts to round forward, you go right there up under the, like if you're doing an L5S1, up under L5, right as the vertebra starts to round. And that's where the nerve root is coming down and out. And so I think I've showed you this before, haven't I? This one. So I wish I had something to point with, but the nerve root is this dark thing right here. That bright spot is the facet, and the middle bright spot is the dural sac, where all the nerves live. So right outside the facet, right here, coming across at this angle, is where the nerve comes out. See that? Yep. So that's why I say go up under the vertebral body of the level above, so the L5 vertebra, and touch right there as the nerve root's coming down and out towards the leg. And then you can get the traversing root right there next to the facet, because S1 is coming off right there next to the S1 superior articular process. And so you can actually stick the probe right under that facet. After I took this picture, I took that facet off. I actually cut along the base of that facet and pulled it out, and you could see the traversing root under there. So I think if they see that, they'll be able to conceptualize it, but you're gonna find maybe a handful of surgeons who've ever seen the nerves like that from the front. Yeah. So either Neuralytix is going to help them feel confident in doing that, or they're just going to be like, you're crazy. I'm just going to slam my cage and I'm never going to test the nerve from the front of the belly. And I'm just going to go from the back and complete it with either a decompression infusion or just perk screws and go for indirect decompression. So it's definitely worth a conversation and some education to these guys, but it may be a hard stop for them, and that's fine if it is. But where I think it can be super helpful is people who do lumbar disc arthroplasty. Because if they're doing it right, they should already be removing the posterior longitudinal ligament. And if they are, they're going to have access to the nerve roots like that pretty easily. Maybe not quite that defined, but they'll be able to get the probe under there because they've now transected that posterior longitudinal ligament, and the posterior disc annulus is gone. And they can stick the Woodson probe under the vertebral body and contact the nerve. So the reason I say it's really big for disc arthroplasty is the shortest disc arthroplasty is 10 millimeters. And actually it feels much bigger than that. And so to me, the times that I've had traction neuropraxias are the times where I took someone with 3 millimeters of disc height, I took a 10 millimeter cage in there, and it over distracted their nerve. I would have known that if I would have had the nerve as I was trialing. It would have been a no-brainer to say, whoa, it was 2, and then I put this trial in, and now it's a 10? Why did that happen? You know what? This isn't safe. Give me the fusion cage, because I can put an 8 or a 7 or a 6 millimeter fusion cage and not have to distract so much. So I think that, number one, and then number two, for a disc arthroplasty, you're not doing a posterior decompression or fusion. You have to decompress the nerves all from the front. So why not have a tool that's going to make you feel confident to know where the nerves are and know where I can take out soft tissue and to tell you when you've done enough.